better to be in person. Let's see here. Oh gosh, let's see, here we go. Yeah. Ooh. That brook trout, all right, so good stuff. I've already, you guys haven't seen that lecture. I've talked about at the beginning, so we're kind of just jump into this. And so cardiovascular, your heart, that was big. Blood pressure, ECG, things like that. Critically important health. The other thing is your lungs, man. Your lungs got to deliver that oxygen to you, especially those interested in sports and athletics. And you got the heart got to deliver the blood to the muscles. And the lungs have to be good enough to load it up with oxygen every time. And you all know that pulmonary circuit takes the blood to the lungs, and the pulmonary veins bring it back, and it's ready to go to the body. Yeah. And normally working out, if you have healthy lungs, it's really the heart. Think about like, I'm going to run this sprint. What is really given out? Is it my heart's ability to deliver the blood, or my lungs' ability to load up the blood? It's usually the heart. Your heart can only pump out so much cardiac output. If you have normal lungs, the lungs can take it. Just keep that in mind. So again, sinuses and your pharynx, your larynx. Cool video showing how vocal cords work. Make sure you see that lecture. And then we move on. So upper respiratory is up here. Upper is everything above your blood spot. Right? So you got upper respiratory infection, you got strep throat, you got sinus infection, that kind of thing. A lower respiratory, you got pneumonia or something gets down in here, it's much more bronchitis, much more serious. So yeah, we're moving down to the trachea is where I left off. So your trachea, I can feel it. The one right here, I feel it. I feel a little rings in there. And these cartilage rings, hyaline cartilage, keeps it open all the time, you know, so it doesn't collapse, right? You want that to be open whether you're in a coma, unconscious, anything. You want this tube open, right? This is your windpipe. So these cartilage rings are not circles, like in a vacuum cleaner tube, they're C-shaped. So the back is open. There's an opening in the back. And well, why? Why? Well, your esophagus is right behind it. So if you're going to swallow something, it kind of lets that food kind of push in a little bit. So it's kind of open in the back. Also, the back, what you have in the gap here is connective tissue, you know, collagen fibers, elastic fibers, it's a muscle too. So you do have the ability to kind of collapse that tube, like make it a little narrow, a little open. Not much, but so this allows you to kind of squeeze that tube more closed or more open, and it kind of like gives some space back there. Otherwise, whenever you swallow something, your trachea will be pushed forward, like a little give back. So yeah, about an inch in diameter for you English people. Oh, gorgeous. So you can see this is all hyaline cartilage. It's dark. It's muscle spanning this, connective tissue. And then the lining on the inside is all going to be pseudostratified columnar with goblet cells and cilia. Wet, it is sticky, any kind of dust you breathe in is getting stuck on there. Here's just a gorgeous cut through a mouse or something. So let's see if you guys can kind of orient yourself. You see here's the trachea here, and then here's the esophagus up here. Yeah. It's a collapsed tube now. When we swallow, it's going to open up. So it's right behind it. Here's the cartilage, but it's open in the back. The trachealis muscle, little muscle, standing back. And then I hope you understand what this is here from your histology. Does anyone know what this are? The point? Thinking of your neck here. Thyroid gland. Thyroid people. Look at that. Those big kind of ponds, you know, with the colloid in it. Yeah. So as it cut through the neck, you're going to see the trachea, the esophagus, and they go through your chest behind the heart. So you've got your heart. This region in the middle is called the mediastinum, holds your heart, pericardial cavity, right? And then behind it, your trachea goes behind it and splits right and left. It's going to split to go to the wall. Just one more view. Take a look at this. This is showing as you get older, cartilage turns to bone. I kind of told you that generally. You can see that little, this is cartilage here. You can see it kind of turns bone. And here's the esophagus right behind. So you're going to swallow right behind, your windpipe's right in front of it. Oh, that's just a gorgeous, gorgeous slide. Oh my God. So pseudo trapped by columnar. Look at the cilia. Oh. And then it's been colorized. The red is going to be goblet cell. You guys don't smoke. You got a nice healthy windpipe. You got all these delicate cilia that are constantly beating upward. And then the mucus is produced. And so any stuff that gets through your nose, it doesn't get filtered by your nose or through your mouth. It'll get stuck in here and then it'll lift it up so you can cough it out. Here's an electron micrograph. Oh. So you look at your windpipe. Oh, it looks like in the ocean when you see all the seaweed kind of waving like that. Just take over. Another view. Oh, look at that. That could be coral reef, but it's not. This is the cilia that are beating in your windpipe constantly. After I worked on this morning. This is a little bit more. So yeah, this is the mucus elevator. Quite disgusting. I'm going to take the mucus elevator. Anyway, this is these cilia are beating upward. So anything gets trapped even deeper in your lungs. The cilia go down into your bronchi, and they will take any. There's a bad guy there, bacteria or something. They're going to bring it up, and you swallow it or cough it all day long. It helps keep your lungs clean. All right, as you go down, again, trachea is like an inch diameter. Then it has to split right and left to go to the two lungs, right? And those are the main bronchi. And where it splits, there's a little keel. It's called the carina. Carina means keel. You study bird bones, they've got a carina here in their sternum with big breast muscles attached. This little carina is the keel, and you can see the right and left main bronchi going to the lungs. This keel is very sensitive. You have a lot of nerves there. So if you suck in, if you breathe in a fly or something and you start coughing violently, if it makes it down to that, it's going to tickle that keel and you're really going to cough. And there's nerves at all the branches as you go deeper, not deep in your lungs, but the main branches, that makes you cough. So coughing I'll talk about is going to bring some of the crap up. Stuff down. We got a foamy in this one. And yeah, first lecture, I talked about the evils of smoking quite a bit at the beginning, but this metaplasia, and I teach this in pathophys, you have the changing of normal ciliated goblet cell mucosa into squamous cells. Yeah, because and then they can be cancerous because you're constantly assaulting them with chemicals and smoke. It's going to change from these beautiful, delicate cilia to just squamous. Therefore, when the morning smokers often cough a lot in the morning, they cough all day because they can't get rid of the bacteria deep in their lungs through the cilia because they're not there. So you have to cough it up violently. All right, well, I teach you guys a little surgical trick. Not really. I'm sure I'm not qualified to give you guys to tell you to do this, but if someone was dying in front of me and they have obviously choking on something, I think I'd give this a shot. Tracheostomy. So tracheostomy is when you have any blockage in the upper tract. Usually, you swallow a chicken wing and your epiglottis is stuck down and it can't open, and the person's turning blue. Try the Heimlich maneuver. Try to force air up so get rid of the obstruction. That doesn't work. Then you can just find the jugular notch sternum. Find its bone here. Then right above it, you can feel your trachea. Right there. And if you cut a vertical incision, you're pretty safe. It's going to bleed a little, but there's no major arteries right in the middle. You make a little hole, that's allow air to come in, and you kind of you bypass the blockage that's high that blocks. So yeah, tracheostomy, and they do this in a hospital at trach tube all the time. They just put one of these in here so you can breathe through your neck. Yeah, so tracheostomy. An ostomy is a hole. Trachea, so it's a hole in the trachea. Any questions? You guys ready? All right. Here we go. Knife. Pen. All right, let's move on down. So the tracheostomy would have been here. But then it's going to get into your breastbone here. So your breastbone is going to prevent you getting to it. Yeah, so this trachea is going to split. It's like a tree upside down. All these branches, branches. Yeah. And so, I guess first of all, this is your bronchi and your trachea, And this is going to be your right and your left main bronchus or primary bronchus. So you have a right and left main or primary bronchus. And then from there, we're going to see you've got 3 lobes in your right lung. First time I'm telling you this, and 2 lobes in the left lung. And I remember it because the right lung is bigger because the heart goes to the left. The heart takes up some space. So the right has 3 lobes, and the left one has 2. And the names are easy, just superior and inferior, and superior, inferior, and middle. So we got 2 main bronchi. And then it's going to branch into, so it's main or primary, to secondary bronchi. Secondary bronchi. Also called lobar. We're going to go 3 to the right, 2 to the left. It's going to go to each of these lobes. So main or primary, secondary bronchi, go to the lobes. And then tertiary would be these colored ones when they start branching more crazy. The right is bigger and more direct. You see that? I'm just telling you that because if you like aspirate something, you breathe in something that goes in the wrong tube. It usually lodges in the right because it's more direct and a little bigger. So that actually for a little trivia. And then these lungs, and again, I told you the lobes, but I'll get into it. We talk about these bronchopulmonary segments. And these are, the lung can be broken, the lobes, into these different segments. They have their own blood supply and their own air supply. Just telling you because in surgery or whatever, they can remove like one of these segments pretty easy. Because you can kind of cut them out as a piece. So these bronchopulmonary segments are parts of the lung that are kind of distinct within the lobes. And something like emphysema, they're removing parts of the lung. It's a normal kind of thing. Parts that are working. Ah, beautiful. So, bottom line, your lungs have tons of blood supply. Remember the pulmonary arteries coming off the heart? Pulmonary veins coming back. So the red and the blue, and they're actually backwards, right? The artery is going to be blue here, the vein is going to be red. But the colors are just deoxygenated and oxygenated blood. So blood vessels everywhere in these lungs. And look at the yellow is the air tubes, the bronchi. So I see a trachea and the right and left primary bronchus. Then you have 3 like lobar bronchi. So looking at this is all put together, you see blood vessels and air tubes. So if you take out a human lung, you're cutting through it, you can follow the air tubes and the blood vessels. So they're going everywhere. All right, here's the lobes. Again, the names are just superior, inferior, middle. And remember, the right is bigger and has 3. The left is smaller because the heart kind of intrudes on it, so there's only 2. And I say that, but in all honesty with you guys, having dissected a lot of cadavers, sometimes there's 3 and 3, So it can actually vary, but this is normal. And then those of you in cadaver lab are going to take it. The lungs in cadaver lab seem kind of solid, like a Nerf football, solid, and because they've been embalmed. In life, they're somewhat spongy, more spongy, but they still feel like a Nerf football or like a lighter sponge. You can press on them. So that's the kind of feel of them, they're kind of spongy. In cadaver lungs, you can see this is going to be a lung. You can see the impression with the aorta pressed on it there. So that's on the list in cadaver lab. And then when you look, this is where everything comes into the lung. So when you look at the lungs, they're sitting in your chest cavity. They're not connected anywhere except at this hilum, where the vessels and the air tubes come in. So you can stick your hand in the chest cavity all the way up the neck, all the way underneath it, all the way behind it. There's room everywhere except where it's connected. So there's 2 connections. It's called the hilus, where everything comes in and out of the lung. What's going to be in and out of the lung? Air tubes, blood vessels, and then nerves and lymphatic vessels too. Yeah, but everything comes in and out of the lung through here. It's the only place it's connected. So if you're doing a dissection, you just get your scalpel and just cut here and here, and you can pull them out. They're not connected in the top or the bottom. And then if you were to identify these things, I don't think you need to, but Just remember the heart, what we learned already, we had pulmonary arteries here, pulmonary veins a little bit lower. So you look at your arteries going to be here, veins a little lower. Okay, you're not going to have to identify that. Just to be confused. All right, what do you think? There's a lung. You see it's right on the diaphragm. It's actually a little bit of space here, it's a little gutter. It's on the diaphragm here. And we'll see, the top of the lung will come into the neck region. Way up high, right? To fill your two pleural cavities in your chest at either side of the heart. All right, let's do this tree. I put the one in italics, I won't ask you about that. But just basically, let's follow this tree down. It's just some vocabulary, like learning streets, like the arteries, you know? So obviously, the trachea is your windpipe. It's going to split into right and left, main or primary bronchi. And then you're going to have 3 and 2 secondary or lobar bronchi that go to the lobes. So 3 in the right, 2 in the left. And then we'll get down to really small things. And then bronchioles are going to be less than a millimeter in diameter. So they're really small. So you're going to see there's a terminal that's kind of like a dead end street, just goes to a bunch of alveoli. And then respiratory bronchioles, we're going to have actual air exchange. So there's some alveoli coming off those. And then finally down here, you're going to have these alveolar ducts, these sacs, and the alveoli coming off these sacs. So these are really, really obviously microscopic. And singular is bronchus, and plural is bronchi. All right, I'm going to show you a picture. We'll go through all of these, but this is the, if I ask you, what's the pathway? This is the pathway it goes. Let's take a look. Ah, gorgeous. Wow. Nice scientific illustration here. All right, so we will see. This is get down to the smallest version. This is an alveoli. An alveoli is a little grape-like dead-end room. And there's going to be little tiny capillaries in the walls for gas exchange. So you can see they look like a cluster of grapes. They really do look like these grape clusters. And that's where the blood is really close to the air. And that's where you exchange everything. And look, starting at the end here, the alveoli are these sacs, these little sacs. And they're not exactly spherical, they're kind of like a polygon, they have different shapes, but these show them kind of like spherical. But these are these dead-end rooms where the gas exchange takes place, the alveoli. And you can see a sac is kind of like this, the main room, and then the bedrooms come off of it. So alveolar sac, the alveoli come off all around. And then a duct, alveolar duct goes to the alveolar sac. And then I'm looking at this particular part of the tubing, and I see an alveolus coming off of it. So I know that's got to be a respiratory bronchiole, because there's some gas exchange. All right, and so as we go down, I can actually make a little thing here. Let's see. As we go down from the trachea all the way down. Let's take a look. Oh, yeah, that's nice. So we go from the trachea down to the alveoli. Let me just tell you, you've got beautiful cartilage. Starts like cartilage rings, and then you're going to have less to none. All right. So the cartilage goes from being these beautiful C-shaped rings in the trachea and the main bronchi, but then it starts turning into these plates. See, like irregular pieces of cartilage. So you're still going to have some cartilage. It provides some stability, but it's not going to be these nice rings. So the cartilage is less and less, and there's no cartilage in the bronch when you get down to the bronchioles. So lots of cartilage to very little cartilage, to no cartilage. Then if I look at the lining, the cells in there, we're going to go from beautiful, tall columnar cells, going to go to cuboidal, down to eventually squamous cells in the alveoli. Yeah. And then what else? That's good for now. As I think of more. So we're looking at this, and yeah, I see little chunks of cartilage. All right, so bronchioles are less than a millimeter in diameter. And you've lost all the cartilage. Yep. Terminal goes to a cluster alveoli. And here it says it goes from columnar to cuboidal, and then it will be squamous in the alveoli. terminal bronchiole, respiratory because it has alveoli on it, alveolar duct, alveolar sac, and alveoli. A little boring. I'm teaching you guys like a map, but take a look at it. Yep, just bringing it down, and so you can see it gets to tiny, tiny, tiny. And to make things more exciting, I'll talk about the function a little bit. The air goes freaking really fast in your trachea. It's like 200 meters a second in the trachea. So air is going fast and turbulent. By the time it gets down to these little bronchioles, it's moving like 2 centimeters a second. So much like the blood system, where it's moving really fast in the arteries, but the capillaries is moving really slow, same thing. Really fast in the big windpipes, then it slows down. It's perfect. And then smooth muscle is of course arranged throughout all these tubes. And so the smooth muscle is where you can control the diameter of these tubes. So really your trachea, your bronchi, you can't make them bigger or smaller very much, just minuscule. But when you get down deeper in your lungs, this smooth muscle, there's no cartilage, it can really contract and squeeze it shut. You guys have an asthma attack, something like that, where you feel like you can't breathe. Those smooth muscles constricted, and it's constricting these airways down there, and you can't move the air very easily. And you take an EpiPen or a Buterol, something like that, it's going to relax that smooth muscle, and the tubes open up again. So these smooth muscles allow you to really control the diameter of these tubes. And just like in the cardiovascular system, the bigger the tube, the less resistance. The easier things move. So you constrict those tubes, it's like trying to suck a soda with a tiny little cocktail straw. It's really hard to do. But a big straw goes really quickly. The diameter of the tube is wicked important in airflow, just like it was in blood flow. And then let me show you these green little lines up here are elastic fibers. So your lungs are filled with elastic fibers, super elastic. And I'll even get ahead and tell you guys this too. When you're breathing in and out, breathing in takes a lot of energy and muscle work, inspiration. But breathing out is just passive. Unless you're purposely trying to blow up a balloon. But breathing out is easy. Because what happens is the lungs get stretched. The elastic fiber gets stretched. And then when you take the pressure off, it just snaps back. So if you have a punctured lung, the lung just stays small. So there's filled elastic fibers like rubber bands. And when you breathe in, it stretches them. And then breathing out, they just return. And it's just like a passive process that the air is going to leave your chest. So elastic fibers everywhere. And a nice healthy lung. And again, when your lungs, there's all kinds of crappy things can happen to your lung. If they lose that elasticity, they don't want to snap back anymore. That's not good. Cool. I'll just show you some pictures. You guys get used to it. So I see there's still cartilage in this. So we're not to a bronchiole yet. Bronchioles are less than 1 millimeter, and they don't have cartilage. So this is obviously some kind of bronchus. Yep. And then over here's a bronchiole, it's got no cartilage yet. But I see smooth muscle around it. Yeah. Nice filled all that stuff. And here's a real lung. You guys saw this picture of lung with the histology. But all these are the alveoli. They're everywhere. These are the alveoli. See how thin walls, squamous cells? Probably heard it. And here's a big bronchus. See the cartilage plate? Big bronchus. And these little ones will be bronchioles. They don't have any cartilage. If you're good at histology and lung histology, these things jump out at you. There should be blood vessels in there too. Oh, just a gorgeous picture of a bronchiole. As you can see, it has a smooth muscle, that nice red, pink stripe around it. And you can see this beautiful respiratory epithelium here. Cilia. We're getting down to almost cubicle here. And then on the outside here, these are alveoli. So these are the normal alveoli with the squamous cells that are going to exchange gases. This is a respiratory bronchiole. Again, maybe I have too much in histology, but you can see there's an alveoli coming off of this. So you know it's a respiratory bronchiole. Start to get some rest. And yeah, you're going to be a bronchiole. These would be respiratory bronchioles because they have alveoli coming off of them. Some beautiful pictures I found that kind of illustrate these things. All right, guys, very patient. Let's see. I'll give you a little more. You guys are good. There's a little more. All right, I'll take a break. All right. So the alveoli. How many do you have? Let me see. Oh, God, I would like average 200 million in your lung. So, a lot. Compared if you look at the two lungs. So all these alveoli, they have so much surface area. Right? Oh, and that's what the lungs are all about. It's lots of surface area because diffusion depends on surface area. Right? The more surface area, the easier diffusion is. The other thing you guys learn diffusion in general biology, one is area, second is how thick it is. Because diffusion goes very slowly through thick material. So you want a wicked thin membrane, you want a big surface. And you make the blood go right underneath the air. And so there's just oxygen, carbon dioxide just going crazy. So thin, wet membrane. It's actually both about the size of half a tennis court. Isn't that crazy? Like shoved in your lungs. Half a tennis court is a surface area. Imagine it's wet saran wrap. And then there's blood underneath it flowing, and there's air on top of it. So that exchange takes place very easily. So we get that surface area kind of like a sponge does by having lots of these alveoli. Cool. So it's a polyhedral chamber. So it's kind of a polygon. Sac, and then be like a mouth. It's like a main room and bedrooms in the mouth. So if you have a sac, and then you have just a view of some. Here's a duct. Here's some sacs, and they'd be like a mouth. Oh, gorgeous. Yeah. So look how delicate that is. These walls are so thin. And those capillaries are running that thin wall. Oh, gorgeous. I'll take a break. All right, so it turns out when you look at these, when you look at this, we have these really thin squamous cells are going to be called the type 1 alveolar cells. Also called type 1 pneumocytes, like pneumatic is air. So there's type 1 alveolar cells. Type 2 are kind of bulgy. They're kind of in the corners here. And the type 2 alveolar cells make this chemical called surfactant. Surfactant. And I put on your blackboard a couple of links to some, for those of you that want to get into it, that talk about surface tension. So those of you interested in physics and biology and stuff, surface tension, you take two pieces of wet glass, they really stick together, don't they? And then honestly, you can like water, you can like drop a little, you can even float a paperclip on water. You know it's heavier than water, but that surface tension, water loves itself. It sticks itself. So the problem is when you have these little sacs, these little alveoli, and they're coated with water, they want to collapse. There's this pull inward, and they want to collapse. So how do we keep these alveoli from wanting to just stick to each other? Because they're so small and they're wet. Well, we make this surfactant, which is kind of like a detergent, like a soap. It's like a soap. The molecule is antipathic. It has a hydrophobic, hydrophilic area. So it's made of fat and then a hydrophilic area put together. And this is good for soap because it surrounds the grime on your hands and it takes it away with water. And it's good in here because it decreases the surface tension in those alveoli and keeps them from collapsing. And it makes it easier to breathe. If you want to listen to that, it's cool. If there's less surface tension in the alveoli, the air flows easier. And so you guys have surfactant in your lungs, because you guys all look alike, right? So you have surfactant in the lungs. It's not produced in the lungs, it's like 35 weeks. Which means if you have a premature baby and the surfactant isn't mature enough, it can have this respiratory distress syndrome in infants. And that's why a lot of real premature infants, the main issue is the lungs. My first lecture talked about that all your other systems are tested before birth. Your kidneys, your heart, they're going before birth. But your lungs, as soon as you're born, they open up and they have to work. And you got to get rid of the fluid, and it has to be surfactant that's coating the alveoli to keep them from sticking together. And if there's not, we have artificial surfactant we can squirt in the baby's lungs, and that will help. And then hopefully their lungs will mature in the babies. So surfactant increases surface tension, keeps your alveoli open. Yeah. Cool. All right, I've been going a long time. You guys definitely deserve a break. Any questions overall? Surfactant? You can think about it. I'll start off a bit. So it's 11:44, we will begin again. Whew, take a breath. Any questions so far? Any questions? That's that enough. Maybe, let's see. We'll get to things like asthma and emphysema, things like that. COPD. So hopefully we got the basics here. We followed the windpipe down. Some terminology you got to memorize: main bronchi, secondary bronchi, tertiary bronchi, bronchioles. So you got to do that. Now we get into the alveolus itself. We'll get right to that. Get into that barrier, how thin it is between air and blood. Let me just show you. This is something that's it's not impressive. That is amazing. This is the size of a blood cell. Red blood cell. So it's so thin, that membrane, which is really going to allow that oxygen carbon dioxide to move like nothing. Yeah, we also use breath for like breathalyzers for alcohol tests and even all kinds of things, because anything that's in our blood, you know, here's the gases in your lungs can bubble out into here, right? So you can tell a lot from your breath, even states of health. And if you're really diabetic, your breath can smell, uncontrolled diabetic, you can smell sweets. Like acetone, you can kind of smell that. So you know the gases, anything in your blood can bubble out into your lungs, into your breath. So it's just such a thin membrane. And that's the air-blood barrier. Yeah, that's going to be the respiratory membrane. Yeah, and later in the semester, the next chapter, we'll talk about this membrane between the blood and where you make urine, where you make pee. So there's going to be this really thin membrane there too. So long membranes are good for filters. In this case, it's good for exchange of gases. So you need that surfactant. Oh, and then so what you can see if you look at this, you see two dark lines and then kind of a light center. And what it is, it's going to be on the inside. This is the capillary. It's going to be the squamous cell of the capillary, the endothelium. And out here's going to be the type 1 the alveolar cell, really squamous cell out here. And the light area of the basement membranes. Epithelial tissues have basement membranes, so that's kind of that light tissue thing there. So if I talk about this barrier, you need to know it has to go, the air goes through that light, thin layer of soapy surfactant. Then it's going to go through the alveolar cell, the basement membranes, and then through the endothelial cell of the capillary. Yeah. So taking blood, putting it right next to the air. Oh my God, it's such a cool picture because this thing here looks like the size of a planet. This is a tiny red blood cell. So it shows you how thin that membrane is. It's crazy. So this delicate thin membrane, this respiratory membrane. And you all know, this is the endothelial cell, the capillary now, but these are the basal membranes. We're calling it a pneumocyte here. I mentioned that. Pneumocyte type 1. I call it alveolar type 1. Wow. Amazing how thin that is. So this is showing it's alveolar sac and alveoli. And the arrows point to some capillaries. So the blood is just coursing in these thin walls right next to the air. The view, all that is the capillaries over these alveoli. So put blood and air next to each other, and it takes no energy whatsoever. There's diffusion. There's more carbon dioxide in the blood, it diffuses into the air in the lungs. There's more oxygen in the air in the lungs, it diffuses into the blood. All right, so you got it? Now we'll talk about later in a disease like emphysema, these delicate alveolar walls break down. Big bubbles. No bueno. You want to be tiny, delicate. All right, so these alveoli are these are the grape-like, sacs there. There's actually pores between them, so they're not. There's pores that connect them. So sometimes if you have some kind of blockage, it can still be airflow. But anyway, zooming in, these things are the macrophages. So you all better know what macrophages are. Some of you didn't know for that last exam, but macrophages are phagocytes. They're big cells that eat bad guys, that eat debris, in this case, smoke, whatever else you're putting in your lungs. These alveolar macrophages cruise through the alveoli. They go through little pores between them, and they just eat particulate matters, tar, whatever's in the lungs. Here's a picture once of huge dust cell, like I say. Eat the dust. Lysosomes. It's just big eating machine, right? Bacteria, virally infected cells in your lungs, macrophages. Oh God, let's talk lungs, man. So lungs, yeah. And we'll see later that athletes, really elite racehorses, athletes are bred, well, the horses are anyway, like specifically, to have, the anatomy to have large lungs. And like I think of a racehorse, the ability to quickly move air in and out. Because they're running on that track so fast that they just kind of move the air quickly. And the heart has to be big enough to pump that blood, feed those muscles to the tendons, for that competition. So, indeed. The lungs sit underneath your chest cavity, protected by these ribs somewhat. You can still get shivved and, puncture a lung, but that's pretty good protection if it hits your rib. And if you notice here, they go into the neck. You can get a punctured lung from a stab in the neck or a gunshot neck. They all have above your crown. Crazy thing. Go all the way down to your diaphragm. Yeah. So your sternum in front protects them, your ribs, the back of your vertebrae protect them. And you got 2 and 3 lobes. We're talking about the evolution. Lungs first came out in fish, there's lungfish, and there's a gut tube, and then coming off it were these little buds. They become the lungs. Embryology stuff, good stuff. Here's a view of some cadaver lungs. Taking a look, so you can see. If you think like it shows in the picture, if you think the lobes are kind of like stacked on top of each other, it's more like a vertical fence. This middle lobe is kind of like a little ear kind of stuck in between. So this is what it looks like for real. You see the darkness on the lungs. It doesn't mean that's a smoker necessarily, but there's definitely going to be carbon, etc. Even in people that just have a fireplace. And then look at the hilum on the lung. Look in here, it's been colorized, but you're going to have pulmonary artery, pulmonary veins, you're going to have bronchi coming in. But the only place is attached to your body. Attached to the windpipes, nerves, and then blood vessels. And the inside looks like a Nerf football. Like I keep saying that. It looks like a sponge, like that sponge. All right, so the lungs are coated with a membrane. Just like the heart. The heart had a visceral pericardium. It had a parietal pericardium inside of the sac, the elbow. It's the same thing. The lungs have a visceral pleura. So these cavities are called the pleural cavities. Pleural. And the pleura are the membranes. And visceral means guts. So kind of a visceral reaction to that car accident, a gut reaction. So just remember, visceral is on the organs. The parietal line's the cavity, the chest cavity. And just like the heart, they're actually connected to the heart. It's just the lungs push into this membrane and they took it with them. So the parietal goes around and then it comes up the hilum, and then it surrounds the lung. It's actually one membrane. But if you look at it, the lung has a strand wrap on it, the chest has a strand wrap on it. You can pull that off of the cadaver. And between the two, this pleural cavity, it's really a potential space. It's a thin film of fluid. And let me just get this out here. Your lungs only inflate because they are stuck to that outside wall, because the visceral pleura and parietal pleura are both wet, and they stick to each other just like a cover slip on a slide. And as your chest gets bigger and inflates, the pleura tend to pull away from each other, and that vacuum makes them stick harder together. And so you have this sticking of the wet lungs with the wet chest cavity, and that's how they expand, because they're stuck to it constantly. If you become unstuck, you've got a collapsed lung. They're normally stuck outside of that chest cavity. So the pleura secrete there's a little bit of pleural fluid, and it keeps it wet and allows it to inflate. Yeah. I don't want to get into too much. You have this gutter down here. If you want to collect some pleural fluid, sometimes there's too much fluid in there. Sometimes there's blood in there. You can put a syringe down here. You don't hit the lung. It's like this gutter that comes down. All right, pleura, yes. You can have infections of the pleura just like you can in the pericardium, called pleurisy. That's why they listen to your lungs, various places. And it should sound smooth, but it sounds rough like sandpaper. You got kind of infection. Yep, this is from your book. I put it here to help you study. So today I just did from the trachea down. The first lecture I did the nose, everything like that. So. All right, we're going to talk about breathing now. All right, we're going to get to some physiology. All right, get the anatomy pretty much down. So one of the things, guys, if you will see, there's a breathing is different than respiration. Breathing is, we just call it ventilation. That's taking the air in and out of your lungs. I'm breathing. But we're talking about respiration. That's dissolving the gases in the blood, moving it to the tissues. There's cellular respiration, right? ATP generation. So, respiration is a much bigger term than breathing. Breathing is just the physical moving the air in and out. And I'll tell you this right away. We have an inefficient way of ventilating. We have what's called a tidal flow. It's like the tides come and go in the ocean. Air comes in and out of our lungs. And there's always dead air in our lungs, right? Oh, you can't get rid of all the air in your lungs. You can't. The best way is we have an exhaust pipe. We take air into our lungs and then the old air goes out, always fresh air. We don't do that. We have this tidal flow where we have this dead air constantly. It works. But birds have more of an exhaust system. So you'll see geese fly over Mount Everest where humans are sucking on oxygen. So birds have these air sacs where they take air in, their lungs are more solid, it goes one direction. It's like fresh air. But we have this tidal flow. And it works, we refresh the air in our lungs. We bring in fresh air. We're never getting rid of the dead air completely. So we have this tidal flow that's pretty inefficient. Let's get to it. You can watch this video if you want. It's just, I thought it was pretty helpful. Let's see. So breathing or ventilation is moving air in and out through the bronchi down to the alveoli. And you all know because of COVID time, we put people on ventilators. So if they're not able to get enough, we can mechanically push that air. Oh, I put this slide in this morning, kind of cool. So we're sitting here, oh my God, I'm close to sea level, teaching a name here. We are 20 feet above sea level. I don't know, how far is this to the ocean? Not that far. So we're sitting here, and above us is this huge column of air that goes up into the stratosphere, right? And there is pressure from all these air molecules, but we don't notice it. It's on us all the time, equally on us. And it's about 760 millimeters of mercury. We call it 1 atmosphere at sea level. And just how we measure it is you can do this. This is a thin tube of glass with mercury in it. This is what we use to determine, like, if barometric pressure, like sailors, what the weather's going to be like, right? So, and then what it is this mercury will go up about 760 millimeters at sea level. It's the pressure of the air around it pushes it down. It's going to push it up there. So we're sitting here at this air pressure. You guys don't notice it because you're used to it, but it's above us, all this air. And in fact, when you guys suck something out of a straw, you guys probably know this, it's the atmospheric pressure pushing the soda down that if you make a vacuum, it's going to push it in there. So it's just, because we have this. In space, it's a little harder to do this, but because this pressure that we have pushes the blood here. That's how we breathe. It's going to be this negative breathing. We make a vacuum in our chest, and the air around us pushes in because it's always going to go from higher to lower pressure. All right. So put that in to explain this. So if you think about just before you breathe, the pressure is the same inside and outside. So the outside and then inside you call it intrathoracic or intraalveolar. That pressure is going to be the same as the outside when nothing's happening. What we do is we make a vacuum. We're going to make a vacuum in there by pushing down on your diaphragm and expanding your chest. It makes a vacuum and lowers the pressure in your alveoli. And because they're lower, the air pressure is going to, the air is going to be pushed into our lungs. It's going to be sucked into our lungs. Make sure it forms a vacuum. Sucked into our lungs. And it turns out we only move it by like, instead of 760, like 758. You know, that's all it takes though, a little bit less pressure. And the perfect, analogy I think is like a syringe. It's perfect. So if you pull back on the plunger, it's going to make a suction air is going to come in. If you compress the air, it's going to come out. It's just going to. Physics people, it's called Boyle's law. It's a relation between volume and pressure. And so this is exactly what we do. This plunger could be your diaphragm. When it contracts, it comes down. It's going to make more space in your chest cavity, and air is going to come in to fill that space. So that's how our air moves. It's called negative pressure. We make a vacuum and it's pushed in. So inhaling is called inspiration or inhalation, breathing in, whatever. We decrease that intraalveolar or intrathoracic pressure just by a couple, right? To 758, just a couple moves. That's all it takes, though. And then you have greater pressure in this room than in your chest cavity. Air goes in. Yeah. And again, positive pressure would be if we pushed it in. We don't do that. We just let the vacuum suck it. The air pressure around us pushes it in. And it's mainly our diaphragm. You guys have quiet breathing. It's usually your diaphragm. And when it contracts, it comes down. And then it's going to make a bigger space in there. It's going to lower the pressure in the chest cavity. And the chest cavity has to be complete. Can't be any holes in it. If you have a punctured lung, this doesn't work. So it has to be a solid container. You pull the plunger down and pull down your diaphragm, it's going to make slightly lower pressure, and air is going to come in. And so normally your diaphragm works really well. And those of you into yoga and play wind instruments, I mean, you worry about your breathing, think about your breathing, your belly breathing, things like that. So you think about this, but if you need more like strenuous breathing, you can put other muscles to work. So your intercostal muscles between your ribs, you got outside ones and inside ones. Those outside ones will lift your ribs up. Your ribs are such that they kind of go downward. So if you lift them up, it makes a bigger cavity, kind of like a pail to handle. If you pull it up, it kind of expands that space. So you can lift your ribs. Hell, if you really need to, you can use like your chest muscles to like lift up your ribs too. To like for like deep, deep breathing. But quiet breathing is usually just your diaphragm going up and down. Chest muscles don't even have to work at all. Oh yeah, and I should mention, for instance, your pec major, like if you are really breathing hard and you hold on to something, I can use my pecs, actually my arm and my chest, and actually move my chest up. Really powerful. We'll see exhaling too. We can use our ab muscles to push the air. So you can use a lot of muscles, but normally it's your diaphragm and then the rib muscles, the intercostals will help make bigger space to bring in more air. Here's your diaphragm, cool muscle. The tendon's in the middle. It starts out at south, the tendon's in the middle, and it goes down, pushes down. So when you breathe, your diaphragm pushes downward. It pushes on your guts, your liver, your intestines. It pushes them down, and it makes more space in your chest. Again, the phrenic nerve comes off your neck, goes all the way down on the outside of your heart to your diaphragm. And again, the pleura. Hope you guys got this. I like this diagram. It shows you how the pleura forms. You see that fist? Around the fist will be the visceral pleura. The vital pleura is left around it. Notice it's just they're connected. So you need adhesion. You need it to stick, the pleura. I'm just reminding you too. You want the alveoli not to stick. You want them to be not sticking. This to be sticking. the books. This will just help you. How we inspire. I'm inspiring you now. Expiration is mainly passive. If you're just doing normal breathing out, it doesn't take any energy at all because you've already used the energy to stretch the elastic fibers in your lung. And then the diaphragm contracts, it pushes down. When it relaxes, it turns out your organs you just squish down your diaphragm, your liver and your spleen and everything, they will snap back, they will push back up. So your guts will come up, your chest will just drop, your diaphragm just relaxes and comes up, and then the lung itself wants to collapse because it has elastic fibers just stretched. So the lungs normally are in a collapsed state unless you use energy to expand. So expiration normally is passive, doesn't take any energy. The energy is in breathing in. Oh, in terms of pressure, I think we just increased it by like 1 millimeter mercury in there as we push the guts up, and that's going to push the air out. All right, so we took out 2, breathe in, and we have 1. We'll make it 1 higher to breathe out. And this is a question you guys will get wrong. I hope not. But when I talk about when you exhale, what happens to the interalveolar pressure? It's going to get slightly higher than the atmosphere. All right, cool. And if you need to, if you're like breathing really hard, you can use your ab muscles, right? You guys, if you laugh a lot or you're really breathing, your abs can actually hurt. You know, if you see a comedy show, because you know as you are pushing your abs, it's going to squish your guts, it's going to push up your diaphragm. So if you're forcing to exhale, your abs will fall. Your rectus abdominis, your transversus abdominis. And of course, this comes to the point, if a person is having trouble breathing, I mean, our first thing is like lay down, but it's actually not the thing to do, right? It's actually easier to breathe if you're sitting up. And there'll be people with lung conditions, they sleep, it's more comfortable sleeping in a chair. Yeah. Because the reason is, if you lay down, all those guts, your intestines and liver, they push up on your diaphragm, it's harder for it to push them down. If you're vertical, your guts tend to sag, so it's easier. All right, questions? Inhaling, exhaling, muscles involved, pressure, slightly lower, slightly higher, is going to move the air in or out. Yep. So you can see tissues recoiling are going to push your diaphragm up, and then the lung itself is going to like just recoil because it's filled with rubber bands. It's just going to wants to get small. All right, positive pressure. And in the medical world, it's one of these machines here, where you squeeze on the bulb and you force air in. So that's positive pressure. And that's how amphibians, that's how they breathe. They swallow air, push it in with muscles. So we use negative pressure to get it back. We can use positive pressure in ventilators and in this kind of machine. Push air into the lungs. All right, this is a picture of someone with a collapsed lung. The word atelectasis, something like that, where this lung has been collapsed. This dark is air, so it's like all we're seeing is collapse. This one's normal. So normally it's stuck to the outside. This one's been collapsed. So if there's any breach in your pleural cavity, such as a stab wound, something like that, air will rush in. You can't make that vacuum anymore. And the lung will just never inflate. You can have one collapse and one fine too. Yeah, and so what you do to fix this is that you find a hole, you put a tube in, you suck out the air so it's a vacuum, and then you plug the hole. So if you make that air tight again, the lung will stick. Pneumothorax, air in your thorax. What do you think hemothorax is? What if you have hemothorax? What's that? Oh, no. You wonder about, if you breathe in, can you burst your lungs? You can't just do that. Come out there, but you can't actually overinflate your lungs because you have this nerve reflex that if you go too stretchy, it tells your brain to stop. So you can't, like, oh my God, I put my lungs out. You don't do that. Just stop. No, hemothorax. Yeah, blood in the thorax. Yeah. So blood can collect in here too, and I can stop it. Yeah. Hemothorax. Yeah. All right, next little subject here. So, in lab, normally we'd have you guys hook you up to this thing where you breathe as hard as you can. We're not going to do that. Next. All right, but you breathe, and we will test your vital capacity. What's the volumes that you can control? And a lot of it has to do with just how big your chest is, how tall you are, male or female, that kind of thing, your genetics. And then, of course, we measure this in health because you can follow emphysema, asthma, COPD, lung cancer. You can follow these things by measuring lung function, lung capacity. So it's called spirometry. Spirometry is measuring the volumes. And those of you in athletic classes, they'll take a look and as you run, they can look at oxygen and stuff like that. But they can look at your lung function, how much volume you can take. But again, if you're a taller person, you normally have to do it. So I'll teach you guys this, and then your labs will also do this over the 2 weeks after. Oh yeah, I'll send an email about if you're in my lab, we'll do the practical either on time or the A group or do it hard after. Practical is all heart, all day. All right. So your tidal volume is the normal breathing in and out. So tidal volume, it's like the tides coming in on the beach, in and out, right? And you need to know it's about half a week, 500 minutes. That's your normal breathing in and out. But my God, look at what you have the potential to do. If you really want a big breath, you can zoom that up 3 more meters. So clearly, just quiet breathing, we have the capacity to really notch it up and start running a race and get on a treadmill, right? So 500 mils is your normal resting tidal. In and out, in and out, in and out. And we call this, you have an inspiratory reserve volume. That's on reserve. You can use it if you need it. So it's my maximum amount. It's going to be my inspiratory reserve off of that normal tidal. You can see it's meters. And then expiratory, if you normally breathe out, you still have air you can get rid of some. Not as much, like about a liter, you can like extra you can get rid of. So that gives you, if you do all of that, like your biggest breath in and then completely blow all the air out, it's called your vital capacity. So your vital capacity is the maximum amount of air you can breathe in and then all you can breathe out. Yeah, well, a lot of that has to do with just your anatomy. And, all right, and let me tell you this. Even if you breathe out completely, like the biggest breath out possible, you always have dead air in your lungs you can't breathe out. It's called the residual volume. You can't breathe it out. So we can't measure that or not. Can't measure that. So, but if you add that part that you can't breathe out to your vital capacity, that's your total lung capacity. See, this makes sense. Your total lung capacity, there's a residual you can't blow out. Your vital capacity is the maximum you can breathe in and out. Your tidal volume is your normal volume that comes in and out. So these terms just make sense, you know. All right, and we would measure this with spirometry. And here's the old-fashioned one. Maybe you have, grandma in the hospital way back. They would use this plastic thing with a ball, ping pong ball that goes up, But now, you have to have a computer. You can measure this. Oh yeah, this one, yeah. Air and like there's water. So yeah, of course we use spirometry to follow people with asthma and various things to see their lung function. Oh, here's real data from a class. The class that we had, like I just input this, I stole it from the curve clouds. And you can see as you get taller, your vital capacity goes up. And then I did males and females. You can see there's overlap in the height of males and females. And then from the literature, there's a little difference in slope of males, slightly higher vital capacity for height. And you can see that sex and height. All right, and this looks complicated with all these formulas. It's really not, though, you guys. It's just vital capacity is going to be your tidal volume plus the inspiratory and expiratory reserve. Total lung capacity is going to be that plus the residual volume. So, yeah. All right, spirometry, good stuff. Now, let's talk more about lung function. So, we have something that's going to be called minute volume. It's how much air goes in your lung per minute. Just kind of like cardiac output kind of thing. All right. But let me just tell you, in your lungs, there's dead air. If I breathe in, let's say I breathe in 500 mils, guess what? A lot of that air stays in my trachea, my bronchi, my bronchiole. It's dead air because it's not going down to my alveoli, right? If I'm breathing in and out, I'm like moving that dead air in and out. So we call that dead space, like anatomic dead space. That's the air just moves in and out of my tubes, but doesn't get down to my alveoli, so I can't use it. Right? There's even like functional dead space. People, if their lungs are crappy, will have parts of their lungs that aren't working. They're not getting any blood supply. So talk about dead space in the lungs. You can't really count all the air that we measure because a lot of that gets wasted because it can't work. I'll put that in there. So we're going to have what's called your minute ventilation. How much air we can measure? How much air comes in and out? That's your minute ventilation. How much air per minute? Then you see this alveolar ventilation. You subtract the dead space. So that's how much is actually like exchanging into the. See that? Yeah. So minute ventilation is just like cardiac output. Cardiac output was heart rate times stroke volume. This is breath rate times tidal volume. Right? How many breaths do you take in a minute times how much air is moving in that minute? It's about 6 liters per minute. Let's just rest it. And then just so you know, you've got to subtract the dead space. And that gives you the alveolar ventilation. So that takes away the air that just stays in your tubes. It doesn't make it down. The alveolar ventilation rate, just give me a ballpark, on that 500 milliliters, about 150 of that just stays in the dead space. So we subtract that and we do alveolar ventilation. All right, so you can measure minute ventilation easily. Alveolar ventilation rate is how much actually is working. All right. Now, I put this slide in here. So we can measure your guys' vital capacity, your tidal volume. These are your volumes. But your lung function, how well is it working? This is what we really test with asthma and COPD, things like that. There's this thing called FEV1, which means how much forced expiratory volume can you do in 1 second? How much can you blow out in 1 second over your vital capacity? Because you got to divide by vital capacity because everyone has different size lungs. This is what percentage of your lungs can you blow out in 1 second? If I say it like that, it makes sense, right? What percentage of your lungs can you blow out in 1 second? And a healthy person in 1 second, they can blow out 80%, 90%. And if it's less than like 70%, you got an issue. And it means pretty much that your tubes are small or filled with mucus. You can't go up that air. So imagine I'm a healthy person. This is how I breathe. I'll breathe over here. But not healthy, it take a long time to come out, right? And so that, and things like asthma and such, I don't have it, but the hard part is not, is breathing out, actually. Exhale. Breathing in, because when you breathe in, your lungs kind of expand and the tubes expand. When you breathe out, everything tends to collapse. But they're already small. So this is how fast you can breathe out in 1 second. What percentage of your lung capacity? That's a lung function. And I won't talk about this too much, but pretty much if you look at this, this is how many seconds. So in 1 second, they blew out like 4 to 5 liters. So they like a lot. That would be 8%. You can see this person, it took them much longer to breathe out that much. You can see that. And then I won't get into lung diseases right now, but so this is a measure that you guys will do to go to the doctors. They're measuring your asthma. They get FEV1 over FEV. It's forced expiratory volume in 1 second. Cool. All right, so now what about the issues? Like, so if you want to, sneezing and coughing are ways that we clear out our upper respiratory system, our nasal cavity, and our lower respiratory system, our bronchi and bronchioles. So if we start coughing, and it can be, you can't control it sometimes. Sometimes you can control it. I can cough about it too, but you're coughing, you can't control if you suck something in, right? And that's going to use your diaphragm and your abdominal muscles to push out anything from your lower respiratory tract. Hopefully that forceful, like you'll close your glottis. If you close your windpipe, you'll make pressure that'll blow up, and hopefully you can clear that. When you sneeze, you're getting rid of stuff in your nasal cavity, getting rid of it up there. And then again, yeah, you can read up a little bit on this. I always thought, like, what's the purpose of yawning? I always thought, oh, well, it increases oxygen levels. Turns out we don't think that's the case. We don't know what causes yawning, but chimpanzees do it, we do it. It's contagious yawning. It's when you're kind of tired or that kind of thing. Hiccuping is when you have this, your diaphragm is just really like spasmically contracts, kind of breathe air in really quickly. Right? And you don't know the cause of that either, honestly, hiccuping. And then, coughing, sneezing, laughing, it's very hard to laughing, crying sometimes. You have to look at the expression, the same kind of breathing. And of course, speech. All right, so asthma, we'll talk about asthma and a couple other things here. So, yeah, asthma is usually it's going to be, you have asthma, but then you got asthma attacks, right? And so asthma attacks can be life-threatening. And what happens, this is what I want you to know. Asthma is when you have constricted tubes and too much mucus. Usually both of those together are going to make your airways smaller. So there's something that triggers it. It could be an allergen, something like that, that's going to make you overproduce mucus, constrict those muscles. Your tubes are small. It's so hard to move air. And what causes it? Oh my God. Well, we don't know exactly. But there's an idea, obviously, you're overreacting your immune system to pollen or dust, things like that, kind of thing. And there's one idea, this hygiene hypothesis, is that it turns out kids that are raised with, go to school, have other kids that have dogs, even pets, they have less asthma. And so, and a lot of other things too. So we think that keeping kids away from dirt and germs is actually makes them hypersensitive and they're more likely to have this. That's interesting. If you look at asthma, this is 2001 to 9, you can see it increasing. You can see it's more in kids, they grow out of it, and more in women than men. So. And Maine is up there, we can have percentage of adults with asthma. I'm not sure what the distribution means here, if I should. And then you see it in the green is where there's lots of asthma. Look at that. The UK, Canada, United States, Australia, New Zealand, is it related to English? But industrializations, we see this in Brazil and Peru there too. So it's possible there's a environmental contaminants or it could be like some kind of virus or something that first triggers it. We don't really know. All right, COPD. That's called, COPD is one of the big killers. I see that on the cadaver tags. I see myocardial infarction, cancer, COPD a lot. And this means you've got a chronic obstructive pulmonary disease. I'm talking about emphysema or chronic bronchitis. And what happens in emphysema is that your nice, delicate alveoli, they coalesce into these big bubbles. And then you've lost the surface area. It's really crappy to exchange. So emphysema is almost always caused by smoking. There's some rare genetic kinds, but it's almost always caused by destruction from smoke. Usually the apex of the lung give these bubbles. These big bubbles, and that's useless. And then here you can see emphysema, you see these big holes. And then lung cancer, of course, looks solid. That's a solid whiteness in the lungs that takes over the lungs. And lung cancer can spread to bones and brain. Causes of it, I mean, obviously lung cancer. Smoking is big, but can be a lot of things. Glad I'm good. All right, we are done. So I have one more lecture for you online this week, so watch that one. Practical this week.